Thank you. I have no relevant disclosures. So typically, when we think about aortoiliac disease, kind of the three ways we break it down is conservative, endovascular, and open surgery. But really, there's another category, which I'll talk about, where we can combine our kind of the best of endovascular and open surgery. So what are some advantages of the hybrid option? So it reduces your morbidity from just a purely open surgical repair. It can minimize your length and extent of your incision, so you can have less wound healing complications. And it can still have increased durability when compared to like endovascular only treatment. And the other advantage can be that it's a decreased time to complete revascularization. So rather than staging your iliac stent and your femoral endarterectomy, you can do it in one setting, which may be important in patients that have a pretty advanced critical limb ischemia and tissue loss. So traditionally, when we have talked about this, as kind of has already been discussed a little bit, there's the task classification, which when it first came out, task A and B was for endo, C and D was for open, and then as our techniques and technology have gotten better, that's really been a shift to pretty much an endovascular first approach. So I think when discussing which patients may benefit from hybrid procedures, knowing the anatomy is important. There's still areas which we've talked about and we'll talk about, like the common femoral artery, where in open surgery, a common femoral endarterectomy still has a very good long-term data. So in addition to anatomy, patient selection is also key. If you're treating a very sick and old patient, maybe can't tolerate an open surgery, that may be where you consider a hybrid procedure, endovascular only approach. So for iliac disease, endovascular first has really kind of become the mainstay of treatment. Iliac stenting with both covered and bare metal. There's some data which was already presented, including the COBEST trials, which show some favorable data for covered stenting out at 18 months and 5 years. Additionally, there's been more recent technology like shockwave lithotripsy, which has enhanced our technical success rates. As disease progresses to the aortoiliac segment, it becomes a little more complicated. We have traditionally kissing iliac stents, but again, you can have these kind of gutters in between, and to address that, some other techniques such as CRAB has, where you place an aortic cuff and then you're kissing iliac stents into that is another option. Additionally, we have bifurcated aortic grafts, so AFX, and a traditional EVAR device to treat more complex disease as you go more proximal and closer to the renals. But really all that can be done endovascular. So what about hybrid? So some common reasons to treat hybrid are access vessels. I think that's still a big major role, so the femoral artery in particular. So if you're treating iliac disease and you have concomitant common femoral artery disease, treating that at the same time is one possibility. The other reason potentially is for prevention of embolism. So if you have an acute thrombus into the iliac artery, doing a femoral cut down, clamping the femoral artery, and then doing an embolectomy is a perfectly safe and is a reasonable option. Other reasons where hybrid approaches come up is for bilateral iliac disease. So in addition, if aortobifemoral bypass isn't an option or the patient's sick and can't tolerate it, treating one side, opening up one iliac and doing a femoral bypass is a potential option. And then finally, in select cases, sometimes we have to deliver our devices from the upper extremity if our access vessels are limited, so that's where another role. So I'll go into more detail for those. So the first hybrid approach that I think is probably one of the most common procedures we do is a common femoral artery endarterectomy with a retrograde stent. So there's not too much data in the literature about hybrid approaches and really their outcomes, but this paper from 2018 compared aortobifemoral bypass versus femoral versus a femoral endarterectomy with iliac stent hybrid approach. And the aortobifemoral bypasses, we can imagine, did have a better patency at 1 year, marginally, which was significant. But the treatment approach was not a predictor of 1 year survival or limb salvage. So half of these patients were critical limb ischemia patients. So here's a case that I did, a 66-year-old former smoker who presents with basically classic symptoms of bilateral buttock and thigh claudication, as well as multi-level disease on the left side, so progressing to rest pain. The patient had decreased femoral pulses and just monophasic pedal signals. So here was the angiogram I did, and I think my Wheatlanders already give away what I'm going to do, but I did a cut down, and you can see this high-grade kind of diffuse external iliac stenosis going into the common femoral artery. So for this one, this is, I think, a great case for a hybrid approach. I did, here's just more images showing that a little farther down. You can see the mid-common femoral comes back, and then that's the runoff further off. So for this, the patient had kissing stents to treat the common iliac artery disease, and then a Viabon farther down. And then after that, kind of like we discussed before, right at that transition point, which is important between the external iliac and common femoral, I used a self-expanding stent, so that way I could just clamp it and then do my endarterectomy right up to my stent. So I think for this approach, the endpoints are key. Rather than staging it and having your iliac artery stents live off a, poor outflow, which could potentially affect their patency, you can fix everything in one setting. You also don't want to sacrifice your endpoints, so, proximally into your common iliac artery and aorta, and then distally into your common femoral. So you really want to see that transition well. I think use of self-expanding stents, like we discussed, is important, especially if you need to clamp it or do a hybrid approach. And then the benefit of doing everything kind of in a quicker setting. Additionally, so another common reason that we may do a cut down is someone has an acute embolus into their iliac artery or extending into their femoral. Doing a common femoral cut down with an embolectomy and angiogram is really a safe approach, and you can clamp the artery and prevent embolization distally. Additionally, I think probably another common approach we have is iliac artery stenting on one side. So in a patient with bilateral iliac artery disease followed by femoral bypass. So here's another case I did, an 80-year-old who presents with acute onset of left leg pain, who had basically a cool extremity with monophasic signals. So this patient got a CAT scan. Here you can see their right common iliac is open, and the left common iliac and external iliac are completely occluded, and there is a small aneurysm there as well. So this patient was in their 80s and looked like they were in their 80s. So rather than trying to do some complex endovascular intervention and trying to reopen a occluded iliac artery aneurysm, we did a femoral bypass, and here's our completion. And then additionally, there was an iliac stenosis, so we treated that with an external iliac artery stent more proximally on the right side. As the disease gets more proximal and more extensive, stenting into the aorta is also another option. So typically, sometimes we see this for aneurysm AAAs where we have to do an AUI and femoral bypass. So I have another case here. So 81-year-old who had a small 4-centimeter AAA with a kind of associated aortoiliac occlusive disease, presenting with bilateral leg claudication, non-palpable femoral pulses. So here's the angiogram, and you can see a saccular kind of 4-centimeter AAA on the distal aorta. Looking farther down, you see a very calcified tight stenosis in the common iliac artery. And looking even farther down, you see a very severe stenosis of the external iliac and pretty much a near occlusion of into the common femoral. So this is another kind of great case, as we discussed, where a hybrid approach can kind of treat all this disease in one setting. So for this patient, I elected to do a shockwave lithotripsy, given the severe calcium, and that opened up the external and the common iliac a little bit more. And then given the suboptimal result, I used a Viabon distally, and then used a VBX more proximally, with a pretty good result and kind of exclusion of that aneurysm. And then there's the transition. Try to preserve the hypogastric on that side since he was mainly a claudicant. And then distally, I did an endarterectomy. So in conclusion, since I'm pretty much out of time here, hybrid aortoiliac procedures are a safe option. They can potentially have the advantage of both open and endovascular procedures, and they can be done under local sedation, especially when you're limiting it to groin incisions. So I think this should be an important part of the algorithm for the treatment of aortoiliac occlusive disease. Thank you.